Okay, class, we're now looking at the regulation of glomerular filtration rate. This actually piggybacks on the last video we did, which was the juxtaglomerular apparatus. All right, where we are is the kidney attempts to maintain a normal GFR despite the body's blood pressure. If the GFR is too high, we mentioned, then substances cannot be reabsorbed correctly. If it's too low, everything's reabsorbed, but if it's too low also, the kidneys become damaged because there's not enough blood pressure to the kidneys. Okay. The three mechanisms to control the glomerular filtration is renal autoregulation. Okay, and a lot of that is what we talked about here with the juxtaglomerular apparatus. Then the neural controls, and then the hormonal controls. Okay. So when we look at it, intrinsic controls. Under normal conditions, renal autoregulation maintains a nearly constant GFR as long as your blood pressure is between a mean arterial pressure between 80 and 180. 80 is a little low, 180, as you know, is high. During very low mean arterial pressure, like in hemorrhage, it cannot work properly. It's too low to maintain a GFR. Autoregulation entails two controls, myogenic, this is intrinsic within the kidney, and flow-dependent tumoroglomerular feedback. All right, now see, both of these come into this. Both of these come into this real quickly. The myogenic has to do with what we talked about, the stretch on the afferent arteriole. The stretch or lack thereof does the renin deal. Okay, that's the myogenic. The flow-dependent tubuloglomerular feedback has to do that the macula densa is way down the road, way down in the distal convoluted tubule. But what you want it to do, you want its efforts to control the glomerulus aspect and the arterial. So it's a tubuloglomerular feedback. The tubes, which would be the what? Distal convoluted tubule, which is way down the road, is feeding back on the glomerular area for the afferent and efferent arterioles. That's that tubuloglomerular feedback. So myogenic is the juxtaglomerular cells in the afferent arteriole, and the flow-dependent tubuloglomerular feedback has to do with the macula densa. Myogenic tone. If too much pressure placed on the walls of the afferent arteriole, vasoconstriction. If too little pressure, vasodilation. We've talked about this. Tubuloglomerular feedback. Macula densa. If the osmotic pressure is high or the salt level is high, this suggests there's too fast of a flow in the tubule. Okay, it appears to the macula densa there is not enough time for adequate reabsorption of solutes. Thus, there are too many solutes in the modified filtrate. In this case, the macula densa sends that vasoconstrictor substance, which we think is ATP, to the afferent arteriole to cause vasoconstriction, thus reduce. If too little pressure, then the opposite occurs. Okay? Autoregulatory mechanisms maintain a constant GFR if your blood pressure is between 80 and 180. Okay? When the MAP is too low or too high, then you got to go outside the kidney for extrinsic controls. That's the hormones and the nerves. What's that? The hormones and the nerves. So let's look at that. Okay? Extrinsic controls. When the sympathetic nervous system is at rest. See, remember, going to the kidney, we already said you really don't have parasympathetic, you have sympathetic. The sympathetic nervous system is the fight or flight nervous system. Making urine is not a fight or flight deal. So therefore, under stress or high sympathetic, you shut the kidneys down. When there's low activity going to the kidneys, then what do? You turn them on. So you turn them on when it's low, right? And they're turned off when everything is kind of high. Okay? So in excitement, you turn them off. And when it's not, you back up to sympathetic and it doesn't. Okay. So When the sympathetic nervous system is at rest, renal blood vessels are maximally dilated. You're not in stress. Autoregulation mechanisms prevail, the intrinsic aspect. Let's go further real quick. Extrinsic controls. Under stress is a part to protect the mean arterial pressure of the body, in particular the brain. Okay. This may even be at the detriment of the kidneys. See, the brain is above the heart. Think about it. If it's above the heart, we've already talked about this, you really need to get the blood pressure because you got to push that blood up against gravity. Norepinephrine is released by the sympathetic nervous system. We've talked about that. Epinephrine is a hormone produced by the adrenal medulla. Both afferent arterioles and efferent arterioles have alpha-1 receptors. We back to blood vessels. The afferent arterioles have more receptors than the efferent. That means norepinephrine and epinephrine will have more effect on the afferent than the efferent. The more norepinephrine or epinephrine or both, the more vasoconstriction of the afferent arteriole, because you're not going to do as much GFR to hold more water in the circulation to give a higher pressure under low blood pressure to perfuse the brain. That's what we're dealing with now. Okay? With little sympathetic stimulation, as at rest, both the afferent and efferent are both maximally dilated. With moderate sympathetic stimulation, just a little bit, the afferent and efferent are both marginally constricted to the same amount. With maximal sympathetic stimulation, as during heavy exercise or hemorrhage, vasoconstriction of the afferent arterioles predominates. That means not as much GFR to give more circulation to the muscles if you're exercising, or trying to hold on to water if you're hemorrhaging to perfuse the brain. Okay? This vasoconstriction causes a significant decrease in GFR because the afferent arteriole is being vasoconstricted, right? Can't bring as much in, so you can't filter as much. And the sympathetic nervous system also can directly stimulate the Renin-Angiotensin system. Okay? Renin-Angiotensin, just to review, is triggered when the juxtaglomerular cells release renin. Renin acts on angiotensinogen to release angiotensin 1. Remember, angiotensinogen is produced by the liver, and it's in circulation. It's an ogen, which means inactive. Remember we talked about that? But when acted upon by renin, which is produced by the juxtaglomerular cells in the kidney, it goes from angiotensinogen to angiotensin 1. Then angiotensin 1 is converted to angiotensin 2 using something called what? Converting enzyme that's produced by certain endothelial cells around the body, particularly that in the lungs. Angiotensin 2 causes mean arterial pressure to rise. It's a powerful vasoconstrictor. It can turn on aldosterone. All the things we talked about before. Go back and review that. Let's go further. Angiotensin 2, what does it do? A powerful vasoconstrictor. Stimulates reabsorption of sodium both directly by acting on renal tubules and the release of aldosterone. Aldosterone is your sodium-retaining hormone. Stimulates release of ADH. All the stuff we talked about. Increases fluid reabsorption, thus increasing intravascular volume. Angiotensin 2 decreases peritubular hydrostatic pressure because of vasoconstriction of the efferent arterioles. And then it works on the mesangial cells. Okay. Renin release. We already talked about it. Renin release is triggered by reduced stretch of the juxtaglomerular cells, those granular cells. Stimulation by activated macula possibly due to increase this. And some direct stimulation. In other words, that the sympathetic nervous system also somewhat directly stimulates these cells. Remember, they are smooth muscle. They are smooth muscle. That means you are going to get some stimulation directly from the autonomic nervous system, which in this case would be the sympathetic. Okay? So here's a little chart you can look at on renin release when you have a chance. Okay? Other factors affecting glomerular filtration rate are some prostaglandins, nitric oxide, endothelin. These are some other things too that I bring up that can also affect that. So a lot of stuff to affect. The GFR is really the most important thing you got there. GFR. Okay. We have something called atrial ANP. Remember, that was produced by the atria, and they cause natriuresis, an increased urination that you can look at here. Okay, what else we got? Okay, secretion. Filtration was taking materials out of the blood and putting back in the kidneys, right? Taking stuff, that's the filter. Reabsorption was placing substances back into the blood. Secretion is removing certain unwanted substances from the blood that were not able to be filtered. Now, recall what I said. When you bring the blood here in the afferent arteriole, you can't filter it all, because what would you have in the efferent arteriole? So you only filter a certain amount of that's coming in. Some stuff doesn't get filtered and has to go back out and go all the way around the body and come back again. Those substances those toxic, wasteful substances that you don't want to have a second chance around, then that's where secretion comes in. Secretion is to take out the blood and put into the filtrate, but not at the glomerulus and Bowman's capsule. Most is done at the proximal convoluted tubule on the secretion, and some is done later. So why? Not all blood can be filtered into Bowman's capsule on one pass through the kidneys. That's where the filtration fraction. If it did, we would lose all of our blood volume into the kidneys. It would remain then to be reabsorbed back. The efferent arteriole will have no blood and dry out. This blood-borne waste and undesired filtration must continue in the blood. These substances must travel throughout the entire circulation until they return to the kidneys for filtration on a second pass. Some of these, the body does not want this to happen, so thus comes the secretion aspect. Tubular secretion purposes disposes of substances, certain drugs, and metabolites that are tightly bound to plasma proteins. Because the plasma proteins are not filtered, these substances must be pulled off of that. But they can't be pulled off here at the glomerulus. They must be pulled off later. Elimination of undesirable substances are end products that have been reabsorbed by passive processes. So some things reabsorbed should not have gotten reabsorbed and must be kicked back out again. And then ridding the body of excess potassium. Since most potassium is reabsorbed, it sometimes must be removed. And also for things like control of pH, secreting acids, or secreting bases for that matter. Tubular secretion is the transfer of materials from the peritubular capillaries to the renal tubular lumen. Tubular secretion is caused mainly by active transport, but some by facilitated diffusion. Usually only a few substances are secreted. These substances are present in great excess or are natural poisons. Okay? Substances such as this here, acid, potassium, ammonium, creatinine, and certain organic acids either move into the filtrate from the peritubular capillaries or synthesized in that and secreted. Penicillin is something that's secreted. For example, cimetidine is. Okay? All right, so we're going to close here. So what have we talked about? We've talked about the GFR regulation, and we've also talked about secretion, the purpose of secretion. So we'll close here, and our next subject is going to be calculating the GFR. Okay, thank you.